Hello and welcome to another update on COVID-19, this time recorded on the 30th of June 2020 with a bit of a break since the last one. The topics covering today, so firstly, and not surprisingly, the recent resurgence of cases in Melbourne, followed by a bit about recovery from COVID-19 in people who've had it, the bit about the question of COVID herd immunity, and then about some updates on vaccine and dexamethasone studies. So starting off with the resurgence of cases in Melbourne. So I'm sure you've all seen the disappointing and frustrating news of what's been happening recently with the rise in number of cases, with a peak yesterday of the current epidemic up to 75 cases in Australia, slightly lower today at 64, but still a very high number of cases and very concerning for what's likely to come from this. Just in terms of keeping this in perspective, if we compare what's happening now on the right of the curve over in June, compared to what was happening 3 months ago at the end of March, early April, certainly things are not as bad as they were back then, with a lot more cases per day. And keep in mind that at that stage, when we had a lot more cases, we were doing a lot less testing than we are now. So in terms of looking for some positives out of this, we are doing a lot more testing now and finding fewer cases than we were back then, but the curve still looks like it's heading in an upward direction at this stage. Also, the cases that we're seeing now so far have not been reflected in a high number of admissions. And back then, 3 months ago, we were having quite a lot of hospital admissions. But those admissions tend to occur in the second week of illness, so perhaps they're still coming, and it's likely that we will see a few. Although in our favour, at least, most of the cases that we're seeing at the moment are people who are younger, so that it may be that they're less likely to end up in hospital. But although they're less likely to end up in hospital, it may be that they're probably more likely to pass it on to other people. So certainly we're in a concerning time, but I think we'll just have to wait and see which direction this is going to go and how far this does go ahead. It's likely to keep going up for a little while yet, but for how long, unclear. So just in terms of that question about how much testing we're doing, so if you look at these pink bars here, with the numbers on the left here, the numbers of tests we're doing per day, back in that time when we had a lot of cases in March and April, we were doing on average about 10,000 tests per day in Australia. Now, if you look over the right-hand side, in Australia, we're doing roughly 40 to 45,000 tests per day, of which about 17,000 are being done in Victoria. So with Victoria having about 25% of the national population, we're doing about 40% of the tests overall. And so certainly it's concerning that we're seeing all these cases, but we are likely to be having a more accurate picture of all the cases that are around at the moment compared to back then when we were doing fewer tests for a lot more cases. So one of the questions being asked about this is this because we're in winter now with the cooler weather? So personally, I don't think this is a major factor. So we're seeing a lot of rise in places that are warm places. And obviously there's a huge number of cases in places like Brazil and India and Bangladesh and Saudi Arabia. And on top of that, if we look at the US situation, there's been a dramatic rise in southern states, so places like Florida, California, Louisiana and Arizona, so places that are very warm. So I don't think we can say that the weather itself is the major issue. It appears that most of the cases are transmitted indoors, which is perhaps one of the reasons why it tends to be more common in cooler times of the year. And it may be that those places that are particularly hot, people are moving indoors to where it's air conditioned and are more likely to transmit it that way. I think probably what's happened in Victoria is that we did perhaps relax our restrictions that were previously around just a little bit too soon, and those cases that were still happening have then spread to a lot more cases, and so we're now reaping the problems associated with that. So what do we need to do at this point? So I think we do really have to go back to that problem of social distancing again. And what do we mean by that? So any non-essential social activities need to be put off for the time being, unfortunately, and we need to go back to what we were doing before and just having a very restricted, almost essential lockdown type of period. If you're going to be with other people, people not in your immediate family or your immediate contacts, then increase the distance apart. So that 1.5 meters, that's a minimum distance. It's not a cutoff of 1.5 meters is all or nothing. It's the further apart you are, the lower the risk. So if you're with other people, try and make it as far apart as possible. Also, there's a factor of the longer you spend with someone, the more risk there is. So reduce the amount of time you're spending with other people who are not in your kind of immediate close family situation. And if you can meet them outdoors, that's much better because it appears that there's much lower risk from transmitting this outdoors compared to indoors. Along with that, that then kind of guides us as to when we need to use masks. So if you're going to be going to the shops, if you're going to be going on public transport, if you're working in an office type situation indoors, that's when you need to think about using masks. If you're going for a walk around the block or going to meet someone at the local park, for instance, then probably if you can maintain that social distancing of more than a couple of meters apart, then there's not a whole lot of benefit to using masks in that situation. In terms of your shopping, if you can, do it online. If not, do it quickly, reduce the time you're spending in the shopping centres, and do it in a mask. If you can, avoid those public indoor places, so places like shopping centres, places like trams and trains and other forms of public transport, and avoiding other forms of things like going to house parties and so forth. So try and do as much as you can outdoors. Continue washing your hands, because a lot of the spread is from touching surfaces and getting the virus on your hands and introducing it to yourself. And then if you do happen to get any form of respiratory infection, so even if it's just a runny nose or a little bit of a cough, but you haven't got a fever, still you need to cancel everything if that's the case. And cancel your kids' sport, keep the kids out of school if that's the situation, because even if it isn't coronavirus and if it's some other sort of more mild respiratory virus, when people are going to catch those, they're going to be stressed, they're going to need to get tested. So please, if you've got any form of respiratory illness, stay home, cancel everything in that situation. Will we need to go back into a formal lockdown situation? Well, obviously the decision has been made today to do that in certain postcodes in parts of Melbourne where there's been a lot of cases. And if cases continue to rise, that will spread it to the rest of the state probably. But at this stage, hopefully we don't need to do that. But unfortunately, we're just going to have to wait and see what happens there. So moving on now to the question about recovery from COVID. So obviously we've seen this thing of, for people who have infections with symptoms, that maybe 20% end up in hospital, and of those, a subset end up in intensive care or potentially even dying. And those other 80% are likely to recover from the illness with a relatively mild form. So whilst that is kind of true, there's certainly increasing reports of people who've had coronavirus who are having ongoing symptoms, even weeks or even months afterwards. The types of symptoms they're talking about, things like aches and pains in their muscles and joints, ongoing cough, sometimes with phlegm, certainly lethargy, diarrhea, sweats, and sometimes even with fevers, the feeling of like burning in your feet, and then losing your sense of smell or taste again. And so how common is this amongst the people who've had infection? It's not quite clear yet, but there's plenty of people talking about having symptoms even sometimes as long as 3 months, who still have not yet recovered from this. So it's certainly quite a concern. And on top of that, there's people with even more serious complications. So we've seen these reports of children and even young adults with this Kawasaki-like syndrome, developing these very severe aches and pains, high fevers, and this funny rash you can see in this top picture. And on top of that, other people, adults, getting things like chilblains in their feet or fingers. And we know that both those things, Kawasaki and chilblains, are a form of vasculitis. And what vasculitis is a form of inflammation in your blood vessels, where it's what's called an autoimmune thing, where your immune system, instead of fighting foreign things like bacteria or viruses, is fighting part of you. So it's kind of overreacting to what's happened and then starting to take out its fight on part of you. And in this case, it's taking out that fight against your own blood vessels and causing a lot of problems with that. So that's certainly a concern. Whether this is how common this is, how likely this is to happen even further down the track for people who have recovered from this, is not quite clear. Could there be other complications? It's something we're going to have to wait and see. We know that when people do develop any form of serious infection that has a lot of inflammation with it, and so examples of that being influenza, pneumonia, or bloodstream infections like septicemia, that in that serious inflammation you get with those, in the 1 to 2 years after you recover from that, there is a much higher rate of people who are middle-aged or older of getting vascular complications like heart attacks or strokes, and even dying from those. And it's pretty likely that in coronavirus, that with the very severe inflammation people get from that, that it's likely to be the case that people will have a higher risk of getting heart attacks and strokes in the subsequent 1 or 2 years afterwards as well. We've seen people during their very serious illness getting blood clots in the lungs and in other parts of the body. So it's likely that, well, it's potential that those types of problems could persist beyond even after you recover, and maybe that we'll see higher rates of these type of blood clotting problems occurring down the track. We just don't really know that yet. And like I said, with that vasculitic or autoimmune thing, maybe there'll be other types of problems down the track for people who've had this infection as well. And maybe when your immune system's been so overloaded by this type of infection, whether that then leads to problems afterwards when you then get, say, a subsequent infection like the flu, again, we'll just have to wait and see whether people do get other immune system problems down the track. So a question that's been asked in this recovery thing is, why is it that death rates do vary quite a lot between countries? Now, if we look at the extremes, so the highest end of the extreme spectrum, Belgium is reporting about 16% of people with documented coronavirus are dying. At the other end is Singapore is saying about 0.1%. So I think probably both those figures are misleading for us in Australia. Why? Well, certainly with Belgium, it's a huge death rate. It's probably reflecting the fact that they're not testing the milder cases, and so that the numbers of deaths as a proportion of the documented cases is very high. In the other end of the example, for Singapore, the vast majority of their cases occurring in foreign workers who are living in huge dormitories with a huge number of people living very close together. And in these groups of foreign workers all living close together, there's essentially young, healthy people living there, and they're getting huge numbers of infections because there's so many of them living in these dormitories. And so the death rate in Singapore is very low because the population who are getting infected is just this specific population of young, healthy people. So probably the death rate overall is likely to be somewhere in the middle there, probably in the range of 1 or 2%, but it's going to take a while to be certain of that. This may, the various types of death rates may be partly about when the epidemic was recognized. If we look at the epidemic curve, this kind of standardized picture you can see here, that when the people in various countries first recognized that this epidemic was happening, when they started to react. So probably in Australia, because of the fact that we're further away and probably from the reduced tourism from bushfires, when we first recognised as a problem in February, March, we were probably way down this left part of the epidemic curve. And so when we reacted, it was easier to get on top of it at that stage. Whereas the other countries who were hit a lot harder, so places like Italy and the US, when they first recognised as a problem, well, probably much further up the curve on this epidemic curve. And so that when they started to react, it was much harder to get control of it. And so that then by that stage, they were already getting a lot of cases, a lot of transmission. And so that it was more likely that the health system was already being overwhelmed by the numbers of cases. So obviously the mention about the numbers of missed cases is going to affect the rate at which you're documenting cases, and so that you can then sort of say how many of the people are getting very sick and dying. There's also the question about accuracy of reporting, and there's differences between countries as to what they will include as a documented coronavirus death. And whilst some countries are a bit more inclusive, and Italy is probably in that example, other countries are probably starting to push away from that. In fact, there seems to be several places that are at least trying to kind of reduce the numbers of reported deaths from coronavirus. And in some places where there's a lot of cases of people being reported to die from other things like pneumonia or lung infections rather than coronavirus. And so if anything, probably the number of reported deaths in some places is being underdone. Another reason why death rates might vary between countries is the population demographics. And you can see this picture in Australia. If you look at the ages listed here down the middle, and then the numbers of females and males in each age group is listed. And you can see in Australia, at least, we've got a very wide range in that kind of middle-aged group, young adults to middle age. And so if you compare that to developing countries, in a lot of developing countries, there's a lower bulge up the top here and a much bigger bulge in the younger population. And so for developing countries, they're probably likely to have a lower death rate overall because the population is in general slightly younger. For places like Australia, and in particular for Italy, where they've got a much higher proportion of older people, then the death rate is going to be higher if there is a lot of cases. Another question is about these numbers of asymptomatic cases. And so people are obviously very concerned about if people do get coronavirus and never develop any symptoms but can pass it on, then that becomes really hard to control this, because obviously it's very hard to detect people who are truly asymptomatic because they're not particularly likely to present for testing. So before we get too concerned about that, I think it's worth reminding the situation of not all people who are listed as asymptomatic cases are actually asymptomatic cases. So there's some, yes, truly asymptomatic cases, and that seems to be more likely for younger people and certainly for children, but not all people are fit in that category. So in some studies where people have been exposed and then been tested, and at the time of testing they were asymptomatic and then the test was positive, quite a reasonable proportion of them have then gone on to develop symptoms in the subsequent couple of days after that. So it might be that they're not actually asymptomatic cases, they're kind of more pre-symptomatic cases. On top of that, there's people who may have had the infection a few weeks back and are still testing positive, and many people who've had it, say, this week, will still test positive after recovery 3 to 4 weeks later. And on top of that, there will be occasional false positives, as described in previous updates. How common are these? It looks like with the huge numbers of tests that we're doing recently, that this is not particularly common, probably in the range of 1 in 1,000 or less than that, but there's going to be some. And whilst that seems to be okay for some tests, just remember that different labs are doing different tests for this. It's not all kind of one test that is being done by every different lab. So each lab is pretty much, in general, develops their own test. So the rate of false positive is going to vary from lab to lab. So moving on now to the question about herd immunity. So obviously there's been a bit of a question about, can we try and just achieve herd immunity by letting the infection run and then developing immunity from that, and if enough people are immune, then the infection would hopefully go away. So this is really an unrealistic hope, though, at this stage. And to achieve herd immunity without a vaccine is really difficult, if not impossible. So if we look at the situation now, how far away are the countries that have been affected more severely than us? How far away are they from achieving herd immunity? It's a long way. So for the US, the numbers of official cases that they know about, at least, currently is at about 0.8% of the total population of the US. And for Brazil, the second highest country at the moment, it's about 0.63% of the total population. Now, obviously, there's a lot of cases in those places that have been missed, but if both of them are reporting death rates are in the range of between 4 and 5%, so it's likely that there's probably 5 to 10 times as many cases that have happened that they have not documented. But even if it is 10 times, which I think is probably a bit too much, we're still way below the level you're required for herd immunity, which is probably in the range of 60 or probably more like 80% of the population requiring that. And even if it was much higher, the whole idea of getting to herd immunity with just natural infection, it just doesn't happen, because once you get approaching that level of 60 or 80% or whatever it is, then you're going to get fewer infections occurring. And then on top of that, you get population turnover with new babies being born, older people dying. And so that then you may have been nearly at that 60 or 80%, but then with the population turnover, you then get below it. And so you never kind of get to that level that you can achieve full herd immunity without a vaccine. And on top of that, there's kind of the whole population, whether you can achieve it in that group, but then there's subsets of the population. So if we look at this one here, if you say have the population here outside a nursing home and then this population here inside a nursing home, and if you take the Swedish approach of, all right, we'll let the younger, healthier people do what they want, get infected, but we'll protect the elderly and vulnerable, then that is kind of a nice argument, but it doesn't actually hold true, because even if you get into this younger, healthier group, if you get to that 80% of people getting infected, whilst that might offer some protection in that group, if then one person then goes into this nursing home and introduces it there, then that population is not protected by the herd immunity outside of the nursing home. And so that they will still be extremely vulnerable and will then have a huge outbreak within the nursing home. And we see something similar with measles in Australia and in other countries, where to achieve herd immunity with measles, you probably need about 93 or 95% of the population to be immune by vaccination. And in general, the Australian population is around about that level most of the time. But there's certain suburbs and certain parts of the country where vaccination refusal is higher, and those places certainly can get outbreaks happening when somebody returns from overseas or happens to develop measles and goes into one of those communities. So there's the kind of herd immunity in the whole population, but that doesn't necessarily affect herd immunity in local populations separate to the whole population. Furthermore, there's the issue of, well, does the individual develop immunity after infection? And we still don't know that yet. So for normal coronaviruses that cause more of a kind of a common cold type thing, we think that you're probably immune for something around in the range of 6 to 12 months. Is this coronavirus going to be any different? We don't yet know that. It's too soon to have an answer for that. So people who've had the infection, when we test their blood afterwards, they certainly, most of them have antibodies present, although not all, but the amount of antibodies people display does vary from person to person. And how long do those antibodies last? We don't know. And are those antibodies offering complete protection? Is not clear. Antibodies aren't the only thing that's important to have immunity against infections like this. So it may be that even if you do have high levels of immunity, that doesn't necessarily mean you're protected in the long term. So could someone get this again next year? It's theoretically very possible. And it's also possible that if they get it again a second time, maybe that partial immunity will offer them some protection and make it less severe next time. But it's also possible that having partial immunity to the infection now, next year, maybe that will mean that you will get a more severe infection because it kind of facilitates the virus getting into your cells at that stage. So it's potential that people who've had it this year could potentially get a more severe infection last year. We'll have to wait and see with that. So obviously there's been a push particularly in parts of the conservative media about trying to achieve herd immunity, and we can't afford the economic costs of locking down and trying to control or even eradicate this virus. And in terms of this argument, personally, obviously I'm against it. So some of the reasons why. So there's this argument that, well, come on, we just have to let this go because it's only old people dying. So apart from the really offensive idea that old people have lower value, which is a terrible concept on its own, there's also the fact that this is just wrong. It's not just old people dying. There's people of all ages who are dying. And on top of that, the young people who are getting sick, whilst they may not be dying all that often, they're often getting very, very unwell. And probably you've seen the reports of the woman in America who had COVID a few months ago and has had to undergo a lung transplant because of failure to recover her lung function afterwards. We're seeing more and more people who are reporting that they're not recovering well, even 3 months plus down the track from their coronavirus infection. Survivors may have long-term complications, and it's very likely there'll be a higher rate of heart attacks and strokes, but other complications potentially could be happening too. We'll just have to wait and see. And on top of that, it may be that people who've had it don't have lasting immunity and could be at higher risk next year and potentially get even more severe infection at the time. And on top of that, we're seeing new treatments being tested, some showing some success already, and potentially there's vaccines coming, which might mean that we can achieve actually a better control of this and potentially proper herd immunity with a vaccination down the track. And so rather than kind of letting a whole lot of people get very sick and potentially die now, maybe we could be able to prevent that in several months or hopefully not too far away. So moving on to a bit of a brief update about vaccines and treatments. So at the moment, there's many groups working on vaccines, at least 140 groups around the world working on that. And certainly some have started testing this in primates as well as humans. And we're seeing some early reports that people are developing antibody responses. But again, antibody responses aren't the only thing that's important in immunity to infection. And so we don't yet know whether that means they are protected. It's not clear. And even if it is protection against the vaccine, we still are going to have to wait and see how long that protection lasts, or whether it's a lifelong immunity or whether it's a 1-year immunity or something like that. We're just going to have to wait and see. So unfortunately, still watching this space, probably quite a few months before we've got any proper answers on this type of area. In terms of treatments, there's been the recent report that the treatment Dexamethasone has been relatively effective in helping reduce deaths in people who are very sick. So dexamethasone is a steroid medication similar to cortisone or prednisolone. So it's not in the anabolic steroid family, it's in the corticosteroid family. So the anabolic steroids used to build up muscle growth in bodybuilders. The other corticosteroids like this one are more in the family of anti-inflammatories, but also somewhat suppressing of the immune system. And so this has been used in people who are very sick in intensive care and has been successful in reducing death rates amongst that very sick group. And that's great because obviously anything we can do to help people here is good. And particularly with a treatment like this, it's old and very cheap. That's fantastic. But we also know that a treatment like this, if given to people before they get coronavirus, actually makes it more likely that they'll get worse. And if given to people who are less sick, it probably makes things worse. So we're still going to have to work out the kind of Goldilocks point of giving this to the people who are sick enough to benefit, but not mild enough that it's actually going to make things worse for them. And it's still to be worked out where is that sweet point that makes this drug ideal in that group, and also the question about the perfect timing when to give it in the infection. So finally, obviously, this is a concerning time with all these recent rise infections in Melbourne. I don't think it's time to hit the panic button yet, but it is time to increase the social distancing again. And unfortunately, to go back to the Zoom parties and to put your social life on hold once again, and to really minimize the time away from home and with other people. So thanks very much for listening, and I will see you again next time. Thanks.